Hi. Today, we will be talking about Kawasaki disease. By the end of this lecture, you should be able to describe the clinical presentation of and diagnostic criteria for Kawasaki disease, identify important complications, and understand the management and treatment of Kawasaki disease. Kawasaki disease is a vasculitis of the medium and small vessels. What exactly causes it is still unknown, although an association with infection is suspected. Up to 1/3 of the cases are associated with an identified infection, such as Group A strep tonsillitis, viral illness, pneumonia, and gastroenteritis. There may also be a genetic component to developing Kawasaki, and several potential gene polymorphisms have been identified. On histopathology, a hallmark of Kawasaki disease is that there are lesions at different stages of progression in the same patient. The disease process starts with the destruction of blood vessels. This leads to repair with fibrous connective tissue and thinning of the media layer. What results is the formation of aneurysms, scarring, and stenosis. There is a very wide variety of symptoms associated with Kawasaki disease. Today, we will only focus on the more common manifestations. The typical patient is a 2-year-old, previously healthy Asian boy who now presents with a high fever for more than 5 days, which has been unresponsive to antipyretics. Physical examination reveals bilateral conjunctivitis, lip fissures, and a strawberry tongue. As highlighted in this scenario, Asians are 5 to 10 times more likely to develop Kawasaki disease than Caucasians. There is also a gender preference, with higher rates of incidence among boys. 85% of patients present before the age of 5. The onset of Kawasaki is acute, and the child is often in good health before this event. Untreated, Kawasaki will last for a mean duration of 12 days. This table summarizes the criteria used to diagnose Kawasaki disease. The most consistent feature of Kawasaki is a high fever that lasts more than 5 days. In addition to this, complete diagnosis for Kawasaki requires 4 out of the 5 of the following features and no other diseases that could explain the illness in the patient in question. 90% of patients present with bilateral non-purulent conjunctivitis with limbic sparing. Kawasaki may lead to other forms of ocular involvement, and patients may also complain of photophobia, which on further investigation reveals uveitis. There may also be changes in the oropharyngeal mucous membrane, presenting as cracked red lips and an injected pharynx. A strawberry tongue is characteristic. A polymorphous rash may be seen. This begins as perennial erythema and squamation, followed by the development of a primarily truncal rash. One of the last features to present is changes in the extremities. Patients present with indurated edema of hands and feet, diffuse erythema of the palms and soles, and desquamation of the fingers and toes. Although lymphadenopathy is a diagnostic criteria, less than 50% of children will have this. If present, it is usually noted in the anterior cervical node. Not all patients with Kawasaki present with all these features. Children who do not meet all these criteria may have incomplete or atypical forms of Kawasaki. However, if coronary dilation is found on 2D echo or coronary angiography, even in the setting of fewer than 5 out of these 6 features, Kawasaki disease should be diagnosed. It is important to remember that these symptoms may manifest sequentially, and Kawasaki disease may not look complete until later on. Therefore, as long as a child has fever, particularly if it is prolonged to more than 5 days, Kawasaki disease must be on your differential list. There are 3 phases in Kawasaki disease: acute, which lasts about 2 weeks, subacute, lasting up to a month, and convalescent, which can last for years. This graph shows the general trends of symptom onset. As you can see, most symptoms occur during the acute phase. This is when the fever and other classic symptoms of Kawasaki manifest. If carditis occurs, it occurs early. Patients may present with tachycardia, an S3 heart sound, and sometimes even symptoms of congestive heart failure. Other severe complications such as pericarditis and high drops of the gallbladder may also occur at this time. If treated with IVIG, children will be asymptomatic after the acute phase. If untreated, the fever, mucositis, and conjunctivitis usually resolve by the 3rd to 4th week. Desquamation of the digits occurs during the subacute phase and may be the only clinical feature at this point. Coronary artery aneurysms, a complication that we will talk about a little later, most commonly first develops during the subacute phase as well in children treated with IVIG. Coronary artery rupture is extremely rare, but if it does occur, it would happen during this phase. The end of the subacute phase is marked by the normalization of lab results such as the platelet count and ESR. Patients are mostly asymptomatic during the convalescent phase. Horizontal bridging of the nails, known as bow lines, may be present. Bow lines are not specific for Kawasaki and are mainly a sign of inflammation. Kawasaki disease is the most common cause of acquired heart disease in the pediatric population. Coronary artery aneurysms occur in 25% of untreated children and 4% in the treated population. Giant coronary artery aneurysms, defined as aneurysms with a diameter of over 8 millimeters, is associated with the highest morbidity and mortality. Fortunately, smaller aneurysms tend to resolve over time. Coronary artery aneurysms may be asymptomatic for a long time, only presenting in the 3rd or 4th generation of life. When they do become problematic, they can lead to myocardial infarction and late coronary artery stenosis. What is worrying is that many children who develop coronary artery aneurysms do not meet the criteria for diagnosing Kawasaki disease. Children presenting under the age of 3 months or over the age of 5 years also have an increased risk of developing this complication. Other cardiac complications associated with Kawasaki include cardiac tamponade, cardiac failure, myocarditis, and pericarditis. Peripheral artery occlusion may also occur, leading to ischemia and gangrene. These are some of the investigations you should carry out or lab findings you can expect to find. With the development of coronary artery aneurysm being the most feared complication of Kawasaki, proper and complete cardiac examination is critical. A pediatric cardiologist should be on board in the management of these patients. An echocardiogram should be done early in the acute phase, shortly after diagnosis. It should then be repeated 6 to 8 weeks after the onset of disease to confirm the efficacy of treatment given. Children should be re-examined frequently in the first 2 months following Kawasaki disease. You should look out for arrhythmias, heart failure, valvular insufficiency, and myocarditis. Patients with Kawasaki disease, especially those at high risk of coronary artery aneurysms, may need to be followed up indefinitely. The literature very strongly supports early recognition of Kawasaki disease and treatment with aspirin and intravenous immunoglobulin, or IVIG. This is critical and has made a difference to the prognosis and long-term outcome of Kawasaki patients. In particular, it is the early delivery of a sufficient amount of IVIG that has made the difference. Aspirin itself has not been demonstrated to provide any long-term benefit. On aspirin alone, the risk of developing coronary artery aneurysms is 20 to 40%. On aspirin plus IVIG, this risk drops to 9% on day 30 and 6% at day 60 of disease. The prevalence of coronary artery abnormalities has also been shown to be highly dependent on the total dose of IVIG given, but is independent of aspirin. Furthermore, IVIG appears to eliminate the possibility of giant coronary artery aneurysms if the aneurysms are present. Start off with high doses of aspirin for anti-inflammation in the acute phase. Then move on to lower doses for antiplatelet action, which should be given until lab results normalize. This typically takes 2 months. IVIG should be started within the first 10 days of disease. However, if patients present after 10 days with continued symptoms, IVIG should still be given. As mentioned, higher doses of IVIG have been associated with decreased prevalence of coronary artery aneurysms. The ideal dosage is 2 grams per kg of IVIG, usually given as a single infusion. In IVIG-resistant Kawasaki disease, clinicians typically give corticosteroids. However, data on the efficacy of corticosteroids in treating Kawasaki disease, and especially in preventing coronary artery aneurysms, is debatable. While it may be beneficial when used in adjunct with IVIG, it has also been shown that corticosteroid use may be associated with higher incidence rates of coronary artery aneurysms. If this is still ineffective, there are other treatment options that can be explored, including infliximab. If a fever occurs within 48 hours of receiving IVIG, this may be a reaction to the medication. However, a fever may persist or return 48 hours after receiving IVIG in 10 to 15% of patients. This indicates ongoing vasculitis and an increased risk for coronary artery aneurysms. Therefore, do not dismiss fevers in this circumstance, even in the case of low-grade temperatures. Treatment with a second and even third dose of IVIG is indicated. Children with coronary artery abnormalities generally receive long-term antithrombotic therapy with agents such as aspirin or dipyridamole, in addition to regular cardiac evaluations. Overall, the prognosis of children with Kawasaki disease is good, with the low mortality rate curbing down further with increasingly timely diagnosis and treatment administration. So in summary, Kawasaki disease is a small and medium vessel vasculitis that typically presents in children under the age of 5 and is an important differential for prolonged fever. Patients can present with more than 5 days of fever, bilateral conjunctivitis, mucositis, polymorphic rash, edema and desquamation of the peripheries, and lymphadenopathy. The most feared complication of Kawasaki disease is coronary artery aneurysm. Early diagnosis and treatment with aspirin and IVIG is key. Combination therapy versus aspirin alone reduces the risk for coronary artery aneurysms.